Hello, hello, hello. Hi, guys, and welcome to another episode of Bent Pages and Bending Bodies. I'm your hostess, Dr. Hannah P. And before we get into today's episode, please go follow this page on Instagram at BPBB Podcast, like Bent Pages, Bending Bodies Podcast. Yep, you got it. BPBB Podcast. You can also find this episode on YouTube at the same handle. This audio will be available on Spotify and Apple Podcast. Yeah, guys, I'm so excited. I have another special episode for you. We have another guest. Oh my gosh, I'm super excited. So today we have Leah. Her credentials, let's be official, guys. MOT, OTRL. So I will let her kind of explain what those credentials mean. But Leah is from Alaska, the coldest state. Goodness gracious. I don't know how she survived there. But anyway, she is from Alaska. She went to undergrad and grad school in Washington State. Shout out to Eastern Washington University. Um, she completed, so after grad school, excuse me, she worked in acute care slash inpatient rehab for about 3.5 years. And then she decided to take her learning to the next level and she completed a fellowship in the Midwest here. That's actually how we met. We'll get more into that later. But yeah, so then she completed her fellowship, basically just kind of specializing in her neurologic field, NOT. And then now she currently works at that same facility, in their inpatient rehab department, and she is on the stroke team. So without further ado, welcome, Leah. How are you?
Good. How are you? Thanks so much for having me on.
No problem at all. How is life, girl? Let's catch up real quick.
Good, good. Just loving life and enjoying post fellowship season and being a primary on inpatient. So life's
Man,
good.
guys, Leah and I went through the trenches. Oh my goodness. I was the PT resident while she was the OT fellow at this specific program. And man, we will have a whole episode about that later, but we were in the trenches together. So it's so nice to see her smiling face after residency life, after fellowship life. And yeah, life is better. All right, so we kind of heard about this in a previous episode, but just go ahead and kind of tell us, Leah, just to remind us, what is occupational therapy? I know what I do as a PT, but kind of what is the difference between PT and OT?
Yes, love this question so much. So, occupational therapy. A lot of people hear about PT, but a lot of people don't know what OT is. So, the best way to describe OT is basically we look at all the things that fill a person's day. So, from the moment you wake up to the time you go to bed, there are a million things that you do in your day that make up your day and make up your schedule and make up your life. So, a lot of the things that we focus on are some things that you take a lot for granted. So when someone gets up in the morning, they've got to brush their teeth, they've got to maybe take a shower, get ready for the day. That means dressing, going to the bathroom, doing all those types of things. All of those are what we call activities of daily living or ADLs. And so that's one big part of our focus as occupational therapists is working on rehabbing those specific tasks. But then the other things that OTs can work on are the things that fill a big portion of the day. If you're a kid and or a baby and your job is to play, there's OTs that work on that. If you are a student or a kid in sixth grade or in middle school or in high school or in college, there's OTs that will kind of work alongside those patients as well. And then you look at things like when you go up in the age, so people that are working or even people that are maybe retired and are in kind of the geriatric stage of life. OTs kind of look at all of those different activities that fill a person's day, whether that's work or school or play. And then we also kind of just look at how the arms are working for those, so the arm strength, coordination of the fingers, and then we look a lot at vision and cognition too. So we have a huge umbrella, which is
Yeah.
again why I love OT. That definition could go on for a really long
No, it
time.
was great. It was great.
Yeah.
So what initially drew you to OT versus like other professions?
Yeah, so I've always been someone that I am very much a people person. I love working with people. I love helping people. So growing up, I kind of was looking at maybe becoming a teacher, maybe becoming a nurse, kind of adjacent to like something teaching related, but also something healthcare. And my mom's actually a nurse and was kind of aware of occupational therapy. So she did a little matchmaking and was like, I think OT might be really good. And I have kind of a creative side too. And OT has kind of a niche for using that creative side. So it kind of blended all my passions. And I actually got to do an internship in high school that was intended for like high school age students who are interested in therapy professions. So I spent the summer after my senior year of high school doing that internship. And I was like, yep, OT is what I want to do. So I started undergrad specifically like pursuing OT. And the rest is history, I guess. So yeah, here we are. Yeah.
I love that. How was it shadowing as a high school student?
It was really interesting. I think the thing that is most interesting is that I think started off my like exploration of OT thinking I'd go into pediatrics. So like 90% of my shadowing experiences were in an outpatient pediatric clinic. I did like a autism camp where I like did like was a camp counselor, but more from like an OT vein of things. And then I did like some like Special Olympics stuff. So it's funny because like a lot of my like early exploration of OT is like peds.
Yeah.
And then, you go through school, things shape shift and change. And then as I came out, I'm like full on adult. So it's just kind of interesting how that can change over time. But yeah.
So you mentioned that like you have a creative side. How does that play into the role of being an OT? Especially like I think when I think about creativity, I'm like, yeah,
Mhm.
definitely need to be creative with kids, right? Because they don't
Yeah.
want to out.
Yes.
But you said now you work with adults. So how does that
Mhm.
creative side still play a part?
Oh, I love that question. So I think before I became an OT, I envisioned like, oh, I can do all this like art stuff and like what you traditionally think of like as a creative side because I love making art. But becoming part of the like medical model and being in hospitals, I've quickly realized that there's the structure of how OTs work in a hospital is just not conducive to literal art, which that's okay. I've adapted and changed, but I think I still love getting to use my creative side. I mean, OT is all about we really are holistic and person focused. So I'm looking at okay, like what are some creative angles or methods that I can use to get people motivated to do what they need to do as part of their therapy and part of their rehab. So I'm sometimes like thinking outside of the box a lot, where it's like this is the textbook intervention, like, this is the intervention as its, like, basic component, but then I'm adding in, like, more creative aspects and components to make it personalized to the patient and most of all, make it motivating to them. So sometimes I use really creative avenues to make the task motivating to them. So that's kinda where I can pull in that creative side of my brain, in a medical setting.
Can you give an example of like just kind of an intervention, like a textbook intervention, and how you could make it a little bit more creative?
Yeah. So, like for example, I just had like an example from yesterday. So, I have a patient that I've been working with, and she's been at our facility for a number of weeks. So, I feel like especially you start needing to be really creative when you have had a patient on your caseload for like multiple weeks, because not only have you kind of started to exhaust the actual physical interventions and resources that you have at your fingertips, like there's only so many times you can do an intervention before they're like, this is so boring.
Yeah.
Or you do it and they're just not motivated and they're not into it and they're just not going to give it their all if they're not motivated. So I had remembered that this person really likes beading as one of their like hobbies, even before the stroke that they had had. And she had tried to express to me earlier in the day, like, I really want to go outside. Like, Midwest right now, the weather is turning into spring, which is so fun. And at our facility, we have like a terrace area that we can take patients out for. So I was like, well, this afternoon, we really need to like target her fine motor. And a lot of times, I mean, there's so many fine motor things that OTs can work with, like pegs and like things like that. But a lot of the things like that are I mean, they're going to target fine motor, but they're not going to be tasks or intervention or items that a person's going to use in their everyday life. But
Yeah.
I know that person loves beading. So I was like, okay, let's go outside. And we're fortunate we have a little beading kit in our closet. So I like took the beading kit and I was like, let's go like work on some like a beading activity. And to her, it's just a beading activity. But for me in my OT brain, I'm like, okay, so these are, I mean, I could go into all the jargon, but I had, when I was writing my note, I had a list of about 10 items. I'm like, cool, we hit all of these different things from a neuro standpoint, from a stroke re-ed standpoint, that hit those textbook uh, points perfectly. But to her, it's just a being activity. And it was
Right.
motivating. And she was way more into it than she would have been if I had just made her do like a peg activity that has no bearing to her meaningfulness to her.
Yeah. No, I feel like I can really relate to that. So in my current position, you know, if, obviously for individuals who it's appropriate for, but
Yeah.
I actually have really gotten to playing a lot of sports with my patients. So yeah,
Fun.
love like soccer is a great example because I am looking for, can they stand on one leg
Mhm.
and that full leg stance balance, especially with the stroke, especially on that, weaker or more involved side. And so I'll have the person, with the good leg, I'll say, okay, stop the ball and then kick it back. And so
Uh-huh.
they're so involved in that task that they don't even realize that they're standing on their impaired involved leg
Yeah.
way more than they would, like a boring or a standard intervention I could do would just be like a cone tap or tap this step or just different things like that. But I'm like, no, this person, they told me that they have kids, their kids are high school age and that they're on sports teams.
Mhm.
So yeah, like one example of I just kind of could relate to you and
Yeah.
try to think outside the box a little bit, be creative for your patients. um yeah, no, I love that. So moving kind of along.
Okay.
So you have been a couple different places, Leah. You started well, obviously in Alaska. First of all, let's just talk about Alaska real quick. Girl, how was that?
I loved growing up in Alaska. Definitely became an outdoor nature loving girl from living in Alaska and growing up there and experiencing those pitch black 40 below winters and then the
Woo,
glorious for sunny summers. So I love visiting there and going back, but I'll always call Alaska home.
man, I'm
Yeah.
like, good. It was fun to visit. I don't know if I could live.
Been.
But ended up moving to Washington State,
Mhm.
um, undergrad and graduate school there. And then you actually went to acute care. So let's talk a little bit about that. How was your acute care experience? What was acute care and inpatient rehab? So kind of what's the difference between the
Yeah.
two and how was it?
Yeah, so I that was my first job out of school. I feel like it was a really great job to have straight out of school because in acute care you pretty much see everything under the sun. For my specific hospital that I was at, we were a rural hospital. So we were kind of the one hospital in that area. And then of course, if people were higher level of acuity or more extreme conditions, they were shipped out to like Seattle or Spokane. But we were kind of just this rural, smaller town hospital. But the cool thing about our hospital, because we were smaller, as an OT, I got to kind of see everything. So I was in the ICU, I was in post surgical, seeing people after like back surgeries, knee surgeries, hip surgeries, all of those. And then I also saw just like generally like all of our general med cases. So people there for pneumonia or the flu or things like that. And then I also would sometimes float down to our ED. So sometimes they would consult PT and OT just to determine, hey, this patient doesn't have the criteria to be admitted, but we want PT and OT to just screen for them to make sure they're going to be functionally safe to return home. And then the other piece of my job, other beyond just the like acute care piece, was inpatient rehab. So our hospital had an 8-bed inpatient rehab unit. So technically a different facility, but under the same roof as the acute care. And so we function as this with all the same roles that any other inpatient rehab would function under, with the 3 hours of therapy, overseen by a physiatrist, PT, OT, speech, 3 hours. But that was just like a little wing of the hospital. So the really unique thing about that is kind of doing both, because I basically split my time 50-50 with that, is that sometimes you'd see people, they'd be admitted and they'd be in ICU. And then eventually you would recommend them and they'd come to our inpatient rehab. And I'd be like, hey, I was your admitting OT when you were in ICU. You were intubated. You could barely open your eyes. And then you will get to work with them through their acute care stay. And then they discharge and come to inpatient rehab. And then you get to see them fully through their inpatient rehab stay. So that is like a really unique aspect that you wouldn't really get other places, is getting to see someone from the continuum of care, all the way from ICU, where they're critical, and then all the way to potentially them walking out of the doors as an inpatient rehab like graduate. So that was a really unique place, and I think it really grew me like exponentially as a new grad, because I feel like in acute care you quickly gain a lot of that medical background that you need for working in a lot of the like medical like fields and areas that you can work in as an OT. So you quickly gain that medical background. Acute care is great because you really rely on our part of that interdisciplinary team. You get really comfortable talking to nurses, doctors, speech therapists, respiratory therapists, physical therapists. And then I think acute care is also just unique because you're just surrounded by so many people. Um, Whereas, like, if you jump into something like home health straight out of school, you're
Ooh,
basically right.
could
Like, so I think acute care is super conducive to that. And usually there's like a good amount of other therapists. Whereas, like, if you compare it to like jumping into a skilled nursing facility where there's maybe only one or two OTs, in acute care and inpatient rehab, those settings are great because you're surrounded by a good, depending on the size of the facility, a good number of other OTs that you can be your mentors in, that you can lead you into the new adventure that is being a therapist.
So what is it like, or is there any difference with individuals in an acute care setting versus like inpatient, outpatient?
Yeah. So, do you mean like the therapist or like the patients that you
I
see?
would say the patients that you see.
Yeah. Yeah. Great question. So, I feel like, so in acute care, a lot of times the role of the therapist is to inform the physician and the doctor and the rest of the medical team, like, what is the trajectory of this patient? Is this patient going to be appropriate to discharge home in like 2 days? Are they going to be safe and able to do that? Are they going to need some next level of care? Because the main thing about acute care is like it's acute. So you are generally expecting that people aren't going to be there for that long. So that, I would say, is like the number one role of OTs and PTs and speech therapists in acute care, is giving that therapeutic perspective of, what's the trajectory of this patient? Are they safe to go home? Or giving recommendations of what is an appropriate discharge plan. And then the other thing I feel like from acute care is it boils down to like the really, really basics. So in acute care, a lot of the things you're doing are like, we are, for PT, we're trying to get to the bathroom. We're walking from bed to the bathroom. And that might be the first time the person's been up because they've been intubated for 2 weeks and they haven't walked. And, or even let's take a step back, sitting up to the edge of the bed. So
Right.
PT is going to look at the balance, they're going to look at the walking, but then OT is like, okay, well, everyone's been giving you bed baths for the last week, or everyone's been putting your socks on and putting gowns on you. How can we empower you and equip you with the skills to be able to maybe put your own socks on, maybe put your own gown on? How can we get you to be able to sit up at the edge of the bed and brush your teeth? So acute care really boils it down to the basics, because ultimately a lot of the patients in acute care are just that. They're acutely sick, they're critically ill. They're not going to have the capacity to do the level of intensity that we can do when they progress to inpatient rehab. So that inpatient rehab is once they're medically stable and have that endurance and stamina to tolerate more. Now, the level of acuity of patients in inpatient rehab can really vary too. But in inpatient rehab, then we're getting to work on not only the ADLs, those activities of daily living, but then we also get to incorporate like arm strength, coordination, vision, functional cognition, return to what we call IADLs, which is instrumental activities of daily living. So the things that other chores, I guess, that fill your life. So the laundry, the cooking, the childcare, the work aspects. So basically, once they get in inpatient rehab, we're still going to focus on those activities of daily living, but our breadth of what we're covering increases tenfold because those patients are more medically appropriate to be able to do those things.
Nice. So, I, as a student, that's the only
Yeah,
time I've been here, and I was like, not for me, not for me.
it's tough.
But
Yeah,
it's definitely a field that you just have to find your niche, and it just wasn't mine.
yeah.
But one thing that I really had to learn as a student, this was luckily my last rotation, so I felt like I can kind of get it. But for our listeners, I guess, what is your clinical reasoning for, okay, this person just had a stroke, right? And well, okay, we're not going to use a stroke because we know that they need more rehab. But let's say, some in the hospital, they just had COVID. Okay, let's just say that,
Yeah,
or the flu, something like that.
yeah.
So you see them in acute care, and then the doctors are like, "Hey, Leah, this person's going to be discharging in 2 days. Where should they go? What kind of things are you looking for them to be able to go home versus for them to be able to go to inpatient rehab or even like a nursing home, long care facility? What's kind of your clinical decision making there?
I love this question. This is great. And that was one big piece that I did not touch on. I was on the floor in the thick of it during COVID. So I was seeing uh, patients on high flow oxygen. That just basically means more than your average tank of oxygen, cranking it up. Like it's the step right before you vent a patient, basically. So I was seeing those super, super critically ill COVID patients. So that was another piece. Yeah. Just skip right over 2020 COVID. Yeah, that was in there too. But so yeah, we did see this. So I guess the thought process that goes through an acute care therapist's mind when they're giving those discharge recommendations. The options are usually home, which is ultimately we all want that for people. We don't want to send people to a rehab place. Like we want them to go home. And then the other option would be like inpatient rehab. The big criteria for that is a person well enough that they could tolerate 3 hours of therapy. Now that's not going to be 3 hours of therapy all at once. That's going to probably be broken up, but could they engage in 3 hours of therapy throughout a day and be medically safe to do so? The other option is what we would call, some people call a SNF or a skilled nursing facility. And that is still going to qualify them for some therapy, but not at that level of intensity of the 3 hours. And then sometimes we would send people to what we call like long-term care, where we're seeing like they have this need that's going to extend for multiple months on end. And we know that trajectory is going to require them to need intensive care for a while. They're going to need the intensive care similar to acute care, but for a very extended amount of time. And probably not be able to tolerate a ton of therapy, then they would maybe go to long-term care. So a lot of times we're looking at endurance and tolerance. Like we can have someone on inpatient rehab that is still pretty medically fragile, and there's hoops that we can jump through to qualify them for that. But ultimately, is that person going to be able to tolerate that level of therapy? And a lot of it boils down to, so like for a COVID example, they don't have like an arm that's not working or something like really obvious, but a lot of times it's that for COVID especially, it's that endurance that gets completely wiped out.
Yeah.
A lot of times too, when we're trying to make those decisions, you look at what was the person's baseline, right? So if you have a person that ends in there and they're like, yeah, I was going to the gym 3 days a week. I was a super busy parent doing all of these things with my kids, working 8 hours a day. Like compare that to where they're at now. Like we're going to need to get you through significant rehab in order to hopefully get you back to that baseline. So I think we also compare like what was their normal and how far away are they from that like baseline, I guess.
Yeah, I agree. I agree. Yeah,
Yeah.
I was down actually in Florida for acute care right in the thick of COVID as well.
Yeah. Yep.
But yeah, I just remember this was like I think at the beginning of my rotation, and I think somebody was like, pretty much bedbound prior to
Right.
COVID, and then
Right.
they were like, so do you think they should go to inpatient rehab? And I'm like,
Yeah.
no, not really, unfortunately, because
Yeah.
if we're already bedbound, there's just not much, unfortunately, that we're going to be able to do as a team, and so that was kind of a hard lesson in that sense. But
Mhm.
the reverse happens too, where they were so active prior, and
Right.
now they're not. So
Yeah, those are hard conversations to have. I feel like as OTs, a lot of times the doctors will look to us like, "Oh, order OT or order PT." And as colleagues, the therapist and I are looking at each other and we're like, "This person was needing total assist for all cares. Like maybe we can refresh some family training. We can make sure they've got a good like stretching program in place. They have the equipment they need." But ultimately, that's our role as acute care or just therapists in general is to recognize like what can we do, what can we provide to this situation that's going to be skilled, and then what beyond that is going to be something that we can train a family to do and that's become more routine and not novel
yeah,
information, right? So
yeah.
yeah.
Well, good. So you went from acute care. What made you decide to pursue a fellowship and a neurologic fellowship at that?
Yes. So, in the OT world, I think that fellowships are relatively a new concept. I think in PT, they've been around for a fair amount of time. So OT, I never had heard of fellowships really in OT school. That was not something that was talked about. But honestly, it was kind of this moment where I had 3.5 years out of school in acute care. I felt pretty solid and comfortable in kind of the general like this is what I do in acute care. This is my role. This is what I do. These are the interventions. But I was kind of feeling this tug, this internal tug of like, okay, what next? Like, I want to advance myself as a occupational therapy practitioner. I want to like know more about something, right? So, whether that is, I was like, how can I get more mentorship or more training or more education to feel like I'm more specialized in my field? Because especially just like PT, OT, it's such a big field. And I think in order to really find your passion, you have to kind of eventually kind of narrow your interest so that you're like, okay, I'm specialized in this area. And I think I kind of hit that 3.5 year mark and was like, okay, I'm ready to like specialize. I'm ready to become more knowledgeable in a more specific like diagnostic group. So I was, for personal reasons, I was already planning a move to the Midwest. And so I was just looking at regular jobs as I was searching. And this fellowship opportunity just came up as a job posting. And it was amazing because as I was reading the job description of a fellowship, the fortunate thing with the fellowship is it is a job. You just are paid a little less because it's more of a mentorship, educational opportunity, but it is a job and you get full benefits and all that stuff. But that's for another time.
Yeah.
But as I was reading this job description of a fellowship, it was like, this is exactly what I was searching for and felt I needed, but didn't know existed. And it's basically that opportunity to continue to be a fully licensed, fully independent practitioner, but with the mentorship to become more specialized and more knowledgeable in a certain diagnostic group. In this case, it was neurology. So I now have this year under my belt of working more specifically with neurological patients. By no means would I ever call myself an expert. Maybe in 30 years when I've been a 30-year-old OT, will I call myself an expert. But I feel like my brain for a specific diagnostic group has been worked a lot more, and I really have a little more knowledge about a specific diagnostic group than I did before the fellowship. So went from more general to a little more specific, but definitely always a work in progress as far as learning and growing.
Yeah, that's awesome. So
Yeah.
now you work on the stroke team. Is
Ah,
a particular diagnostic group that called to you, or what made you choose stroke? I love
yeah.
stroke. What
Yeah.
made you?
stroke is, well, I guess to kind of back it up a little bit, after working a whole year at this facility, for the fellowship, I knew I like wanted to figure out a way to stay there. So, it was one of those things, you got to put your foot in the door and you got to like kind of put in some time before you can get like the golden spot. Right. So I did a lot of like, coverage work for a first couple of months where I was floating among all the teams, which honestly is great because then you see everything. And I want to keep my skills up on all the diagnoses and all the different floors. But then honestly, like a position opened up on stroke, and I'd always kind of had a passion for the stroke population. And I think the really unique and exciting thing about stroke in particular is the neural progress that you get to see as a therapist, like happening right before your eyes. Like you get someone and they're fully in bed, they can't move their arm or their leg, and then day by day you get little tiny progress, and you're like, you can tell them on day whatever, week 6, that you're moving your arm now, but you couldn't move your arm when you came to us 6 weeks ago. So just the like, and unfortunately, it does not always happen that way. And it's not necessarily an individual's how hard they're working or how hard the therapists have worked to get them. Sometimes it's based on the stroke. But in a great world, we love to see that progress, and stroke is conducive to that.
Yeah.
Whereas sometimes other diagnoses are not as conducive to that, like huge progress that you get to see happening. So it's very cool.
Because I remember we're like, man, I really love, spinal cord injury team.
Yeah.
I was like, that is for you. No, wrong. I feel in terms of PT, it can be very routine. We're kind of working on those same skills pretty frequently. And I just also felt there was just a lot more case management and lots of more planning that involved. And so I was like, oh wow, that surprised me that you love me. But then I'm glad to hear just from my point.
Well,
So
it's funny how things happen because yes, 6 months ago I was like spinal cord all the way, and then as you know, nothing is ever in your control,
right.
and I ended up going to stroke, and I like love it, and I can't see myself anywhere else. So
Yeah.
I feel as a clinician, you kind of have to, be an advocate for what you're hoping to like specialize in, but then also kind of keep your mind open to different diagnoses, and you may find something that you didn't realize that you'd fall in love with, and here you are.
I love that. I love that. So yeah. So now you're on the stroke team. Congrats.
Thank you.
Okay, so let's go on to some other questions. Of course.
Okay.
So let's talk about, at your facility, you guys have a lot of really, really cool equipment. So I guess what is one way that you can see, the OT or just, I guess, the health professional world advancing, especially when it comes to the use of different types of technology and adaptive equipment?
Love it. Yes. So the cool thing about being a therapist is, we as PTs and OTs, we get to introduce people to all kinds of cool gadgets and gizmos. Sometimes they're really basic and really very basic technology. So reachers and sockets are my bread and butter. So we'll introduce that. But then at our facility, we're very, very fortunate to have access to some pretty amazing technology. Various different formats of electrical stimulation. So that's that input that we can give via electrodes to different muscle groups to stimulate those muscles into firing in functional patterns. A lot of times after stroke, you will have like what we call hemiparesis or hemiplegia, where you have non-use of one side or weakness on one side. And so we have various forms of electrical stimulation that we can use. So sometimes that's just the electrodes on the skin and firing those muscles directly. But then we also have like units that go around the hand. That's more like a robot where it's like enveloping the hand and I'm just like moving my hand around here. Enveloping the hand, like electrical stimulation. We also have a unit that I just used on a person today, and I love it so much. You can put 12 leads on a person at a time. So it goes 4 on the forearm, 4 on the upper arm, two on the shoulder, and then 2 on the back. are kind of like the shoulder blade area. And so it's firing on 12 spots, and then you're getting someone able to do a full cycling motion, even with an arm that has no power on its own. And then we have just like all kinds of other equipment too that even doesn't have the eSIM component, where we can put someone's arm in basically a robot, and that machine will move the arm for them and help them to retrain those patterns. So that's like one thing that I selfishly, as an OT, love about this facility is just the technology that I have at my fingertips and the opportunity to use that. And then just the fun of getting to introduce it to patients. Like, oh, we're going to put your arm in a robot today. And like, how cool is that? Right. So, but yeah, we go from all the way from basic reachers and sockets, sorry, reachers and sockets, but they are basic. And then go all the way up to like that 12 lead electrode cycle where you're getting to like watch someone see their arm move for the first time in weeks, which is amazing.
Yeah, I'm sure. One thing I never got to use at that facility at the time, but I think I read a couple research articles involving PT, and I you did an article about this. Virtual reality. Do you use it?
Yeah,
And if so, I guess how would that work? What would you be working on with the virtual reality unit?
love
Unit.
that. Yeah, so I guess one of the good problems to have is that there's so much technology at our facility that there are some things I haven't really used much. But yeah, we are super blessed to have virtual reality like sets basically, and we just had an in-service on this like a week ago, so I can tell you the latest and greatest. But honestly, from an OT perspective, it can work on. So again, it goes back to that creativity piece that we were talking about earlier, where yes, we can give someone an arm exercise and say, let's do 20 bicep curls. Like, who's going to want to do that? For right? But the cool thing about the virtual reality is you can select just like this immersive experience where you're like, okay, I really need to work on this person's arm mobility or their range of motion. I really need to work on this person's strength. So you could put them in that immersive environment, put them in that virtual reality, and then maybe you are giving them a weighted dowel, or you are making them sit at the edge of the mat table and work on that trunk control, but they're in virtual reality. So it seems way cooler than if they're just sitting in the boring gym moving a dowel around. So the virtual reality is really cool. I feel like I should tap into that more for my like interventions. But again, a good problem to have. We have too much technology at our fingertips that I don't have enough time to do all of them. But
Yeah,
yeah, take
just
away that.
definition for that too.
Yeah,
I feel like
yeah,
some of the old grumps may not want that, but if you
right.
get
Exactly.
a younger individual, they might be really into that.
Yeah, yeah, you got to know your clientele, right? Yeah,
So cool. Okay, so let's talk like patient stories. Um,
yeah.
what is something, do you have any stories where you just felt like, obviously people are going to recover how they recover, but what's a
Right.
story you felt like you really had a major impact, and it just made you feel
Yeah,
happy to be a part of that journey and be an OT?
yeah. I mean, I live for those moments as a therapist. I'm sure you do too. It gets sometimes the job, just like any job, there's mundane parts of it, there's stressful parts of it, and sometimes you're like, why am I doing this? I wish I was on a beach somewhere, right? So like those are the things that those therapy moments are the things that keep you going and remind you why you do what you do. So I'm always on the lookout for those moments, and I have a couple. I'm trying to think of one that would be. So here's a good one. So one thing that I personally like to do, and I don't know, some therapists like to do it, some people don't, but I love to incorporate. We have laptops for our like charting, and we like do kind of point of service documentation. But I like to use my laptop to play music for people because it just adds another element of fun to it, right? So I think like our jobs can become mundane, especially in inpatient rehab where people are there for weeks on end doing 3 hours of therapy. Therapy for the patient can become mundane because you get 3 hours of therapy every day, 5 to 6 days a week. So I like to say, okay, so what's your favorite type of music? And I get to listen to a lot of fun, different music through that. And this particular patient, I had worked with her for maybe 3, 4 weeks. She had come to us fully dependent. So that looks like needing to be using an overhead lift to get in and out of the bed. needing 2 to 3 people to be able to help her to get out of the bed, needing 2 to 3 people to help her get dressed, 2 to 3 people to help her go to the bathroom, what we would call like fully dependent on cares. And she was an interesting one. She was kind of slow to progress, like that first half, where we were continuing to teach her the techniques that we would traditionally teach a stroke patient, but the progress was rather slow. And we're kind of like, is she going to need to go to another level of care before she goes home? But I do remember like the final stretch, like the final hour, right? Like the week where she was supposed to be going home. And I was like, oh, I hope she's going to be okay at home. Like, I hope she's not going to have a fall. I hope her family can control, like, be able to help her in the ways that she needs to be helped. And I was like, so like, what music do you want to listen to? And she's like, R&B. And we like were listening to music, and I literally had it on like some shuffle playlist
Yeah.
sitting there. And I was actually doing my discharge assessment on her. So when you do a discharge assessment, you're like seeing what they can do, and you kind of have to sit on your hands and see like what can they do without a lot of my help, and what level of assistance are we discharging them at. And she's just sitting there. She's putting her own socks on. She's putting her own shoes on. And in the background, I don't know, you'll have to like add an insert to this or whatever, but the Neo song Miss Independent was playing on the playlist. And I was just like, it was one of those moments I was sitting there and I was like, I'm not going to make a big deal out of this, but she's sitting there, she's grooving to her music, she's putting her sock on, which she hadn't been able to do like 2 days before, mind you.
Love
And
it.
like Miss Independent, she's playing in the background. And I was like, this is
Girl, you are
like
independent.
perfection. And I was like, she's grooving, she's independent, she's putting her own sock on. And it was one of those moments you're like, okay, like I got to see it from start to finish. She doesn't realize the amazing progress that she made, but I got to see it. And I pointed out to her, I was like, you could not do that like a couple days ago. And now you are. And now we're grooving a Miss Independent together. So that's one of my favorite stories. Luckily, as a therapist, you get those fairly often, but those are the ones that are like, yes, this is what I was meant to do, and this is why we love our job, right? Yeah,
So not to bring the mood down, but what
yeah,
being OT tough? What's something that
yeah.
it's be a not so successful moment where you're like, oh, why am I doing this? Or am I making an impact in somebody's life?
Mhm. Yeah, I think I guess I don't have like a super specific one right off the top of my head, but just generally speaking, especially when you look at the medical model, which is unfortunately the only kind of context I have that I'm thinking of right now, but um ultimately you are seeing people in the hospital. No one's there because something amazing happened. Everyone's there because something unexpected, traumatic, scary, terrifying has happened in their life. Like, as much as we try to make it a lighthearted and fun environment, at the end of the day, we have to remember this person has just experienced a traumatic event, a scary event, an unexpected event, or illness, or accident. Their world has been turned upside down, and they are now having to face like what this new normal is. So I think as therapists and as, these healthcare individuals or therapists in general, I mean, you would encounter this in any setting as a therapist, but you have to become really comfortable with seeing people in emotional states, interfacing with people when they're maybe not so nice or not so polite. I've had so many conversations with people that are tearful. They're crying because they don't know what's next. They're upset because maybe they just got a cancer diagnosis. I remember one time last year, I walked into a room and the patient had literally just gotten the news that their cancer had returned. So you get stuff like that. Or I had a patient crying today because they didn't understand where they were going for their discharge. They didn't know what was going to happen. They were scared. You have people that are in pain. They're going to be like cursing you out because they're in the most unimaginable pain they've ever experienced, and they can't even think about doing therapy. And then you have people that are just plain anxious. Like, a lot of anxiety is a thing that you have to interact with a lot. So I think, and as I've gotten into, going on 5 years now, I've become more comfortable with this. But again, it's always an uncomfortable situation when you're interacting with someone that you may have just met 5 minutes ago, but now they're crying or they're angry at you or they're anxious. And you have to like pause within yourself and put on your therapeutic use of self, because when someone is anxious or when someone is angry, your natural instinct is to have that same kind of feeling build up inside of you. But um, being able to meet people where they're at, present them with the therapeutic use of self, which is the OT term, but the therapeutic use of self that they need in that moment. And the other thing is not everyone needs the same thing all the time. And so you have to kind of really be a dynamic individual, be able to read the room. And that's something that I've had to learn how to read the room, but to just handle these tense situations. And sometimes it's not even just with the patient. A lot of times you're also dealing with the family dynamics and the
Yes.
family that's involved and maybe some undercurrents of challenging family dynamics. So I think just all of that rolled into it is just the emotion, the situation, like that is challenge. I would say that's challenging, and that's something that you can't really plan for. You could have a beautiful treatment plan in mind, and then you walk in and the world has been turned upside down, and your little cute little treatment plan is going to go out the window, and you have to be able to switch like that and be professional in that moment and meet the patient where they're at.
Yeah.
Yeah.
What are a couple ways you go about convincing somebody that, I know you're going through something really, really
Yeah.
hard. I don't get it, but I hear you. And that's what I'm trying to say more often is I hear you. I think that people sometimes get offended by that, but I don't want to say I understand, right? Because I don't that because that's angry too. You don't understand what I'm going through. You've never done no. Okay. I hear your concerns, I can see where you're coming from and that you're in pain and that you don't feel like getting up for therapy. But we have to make this time together.
Right.
You have 3 hours. And
Yeah.
inpatient rehab, guys, inpatient rehab, it is down to the minute. Okay, you
Hmm?
clock yourself in. I entered this room at 1:29 p.m. and I left that room at 2:29. It's right on the dot. 2:30, whatever. That's 61 minutes right there, and
Oh no.
then might have to cover that, or you might have to go back. So, especially in the inpatient rehab setting, how do you go about convincing individuals? Yeah, you should work with me, and we should, get our time in, and this will ultimately help you be better.
Yeah, I think that is a very challenging conversation. And it's a situation and a conversation you have to deal with very delicately, right? I think it's a situation my ability to handle and communicate it has changed drastically from when I was a 1 month old OT to when I'm 5 years. Not to say that I'm perfect at it and by any means, but I think what it boils down to is you have to figure out what's going to motivate them and where they're going to see the value of it. So a lot of times people will say, "Yes, I'm in pain," or "I don't see why I need to do this," or all of these many reasons. But sometimes I got to take it from an angle where when they're saying, "I don't want to do it." Well, you I know you don't want to be here anymore. I can tell that. I can tell that you're not wanting to be here, and flip it on them a little bit. Say, "I know you don't want to be here. That means you want to be able to go home, right?" And kind of put it on the system a little bit. Sometimes they're like, "Okay, I know you don't want to be here. I hear you. I know it's annoying that we keep coming in. These are the stepping stones that you have to do to be able to get home, right?" So if you can kind of flip it on a system like what's going to motivate them, like, yeah, if someone's like pissed about being in inpatient rehab, they're like, "I don't want to be here anymore. I'm tired of you people messing with me. If this is maybe what I have to do, I have to work with this lady for 30 minutes because that's what the doctor needs to be able to see to sign them off to go home." Then you can kind of flip it on them a little bit and be kind of like play the little play game, like, and "I know you don't want to do this, but this is how you get to what you want to do, which is to get out of here." So
Yeah,
sometimes you kind of have to flip it because sometimes I could stand in there all day long and say, "These are the benefits of therapy. It's going to get you stronger." And sometimes that works. Sometimes people need that like educational piece. But on the other hand, sometimes people don't want it. They're tired of hearing education and they're just like, "What's the direct benefit of me to work with you?" And I'm like, "Yeah, actually, it's to get you home, which is what you want to do." So
yeah.
sometimes it's
So,
tough love, sometimes it's education, sometimes it's pulling up a chair and being a counselor. Like you have to be
yep.
very
You
very dynamic.
wear all the
All
hats.
the hats, right? Yes. Yeah.
I often refer to myself as like a pusher. Actually, my job said they're going to a shirt that says the pusher, and I was like, that sounds. But
Yeah.
um, one of the things that, especially in my current setting, that I specifically try to do is like, I want to know your goals, like from the
Right.
get. I'm like,
Yeah.
what do you want to get back to doing? Cool, because at these times when you don't feel like working with me, guess what? I'm going to
I
bring out your
love
goals. You
that.
told me that
Yeah.
you want to get on your boat again, right? I don't have a boat. I'm not lucky enough. You told me that you want to walk your daughter down the aisle without having, a cane or a walker. You told me that you wanted to go, I don't know, dancing with, what I mean, whatever the case is. I'm a very much a you, like
Yeah.
these are your
Yeah.
goals.
Get back on them.
And I also say, my goals are your goals. I'm not doing this to be a dictator. I'm not doing this to just come in your room and annoy you and wake you up out of bed. Like I want the best. I want what you want for yourself. Okay. Because sometimes I find that I want a little bit more for people and I gotta reel it back. But
Right.
want
Right.
what you want for yourself, right? If your
Yeah.
goal is to go back home and to be able to climb the stairs and or to go back, running marathons or whatever the case is, like let me know. And if it is within your
Mhm.
balance, if it's
Yeah.
appropriate, we will try, but yeah, so I just find that like sometimes convincing people is a little bit challenging, but definitely bring out, their goals or just saying, hey, I know you don't want to be here. These are the things that it takes to get you home, right? I know you don't want to work with this, but like again, you said you want to be back out on the water, so this is what we need to do to get you out there, right? So I don't know.
Yes.
Interesting.
Crazy. That.
So kind of wrapping up a little bit, what do you, if any, do you have any advice for individuals looking to get into OT? Kind of, could you, if you, yeah, let's just talk about that first, and I'll ask the next
Yeah.
question. I'm going to ask too many questions at once.
Yeah, no, I love this question. I think, first of all, OT or therapy in general, great, wonderful career to get into. I think the opportunities to shadow are huge because, getting that experience of just getting to be a fly on the wall, really for any healthcare profession, right, or any job in general that you want to do, before you jump through all the hoops of getting into school or being in school, you want to have had that opportunity to kind of see what it's like, right? So and also like getting experience to be able to shadow in maybe different settings too. So like I said very early on, I did a lot of like pediatric shadowing, but I also got to do some like hand therapy shadowing, and then some like inpatient too. So just getting to see kind of what does a day in the life of an OT look like? What I'd be able to do, and I think that helps motivate you as you're going through, because you're like, yes, I saw this OT doing this, or I saw this particular patient, not as a therapist, but as a wannabe therapist, I guess. And you can be like that, like that's what I want to do, and that's what I saw, and that's what I want to be able to do when I come out on the other side. So definitely um yeah, shadowing is huge. I think there are places that have, like, I know at my school we had like a pre-OT club that I was a part of. So like kind of finding other like healthcare individuals or other people, if you're in undergrad, that want to do that too, and kind of teaming with them, and being inspired by them. What are other things? Yeah, lots of just like take opportunities that are available to like get shadow experience. Volunteering is another angle that you can do too. Like I know sometimes shadowing is really hard to like get in because everyone wants to shadow, right? But if there are opportunities to maybe volunteer where you're like, oh, I could see the OT angle of this, I think that not only gives you more exposure and experience. So maybe like if you're volunteering at like a nursing home, or you're volunteering for like say Special Olympics or something like that, where maybe it's not OT directly, but you're interfacing with those communities that you would interface with as an OT. And also it looks really good on an OT school application, because a lot of healthcare and schools in general look for those volunteering. So on the other group of things, like shadowing is great, but so is volunteering, because that's going to get you kind of that exposure to those communities that you need ultimately to decide that you want to go into OT.
Yeah. Real quick, I forgot to mention this in
Yeah.
the beginning of our interview, but your credentials, can you kind of tell our
Yeah.
listeners what that
Mhm.
means?
Yeah. So for occupational therapy, just a quick like 101. So occupational therapist entry level currently is a master's degree. So all occupational therapists have a master's degree to practice. There are two other directions within that. So to become an OT, you have to have that master's degree, but you can also become an OT by way of a doctorate degree, where you would have like what we would call a credential with OTD, where you have an occupational therapy doctorate. You can also go that by way of becoming what we would call an assistant. So there's physical therapy assistants, there's occupational therapy assistants, and those are therapists that work right alongside OTs, which OTR, which I can explain that too. But that is more of an associate's degree, and they are basically working on the towards the goals that the OT sets, and working right alongside with the patients, doing all the great patient interaction that we love, but with that associate's degree rather than having to go all the way through the master's degree. So for my credentials, that's MOT. So I have a master's of occupational therapy. That varies from person to person, program to program. So some people will have like a master of science, and or different like master's degrees that their OT school provided, or not provided, but that they graduate with. So mine was a master's of occupational therapy. And then the important letters at the very end, the ones that matter the most,
Right.
OTRL. So the R is registered. So registered signifies that you have taken your board exam, which is through um, our big board, or a big body of occupational therapy, which is the American Occupational Therapy Association. So the National Board of Occupational Therapy is that's the only way you get your R, is you have to sit for the board exam. So that's the R, and then the L is license. So each state requires different requirements to become licensed in the state. Now, currently in occupational therapy realm, you do have to be licensed specifically in each state. So if you are starting in one place and then you end up moving, you have to get a new license for each state. But those are those magical letters. The R is the fact that you've taken the board exam and you never want to let that lapse. And
Ever.
the
Ever.
and then
Sorry.
you may end up like having that come and go depending on if you're keeping your license up. R, again, there's scenarios where maybe you've let either of them lapse. If you let the R lapse, then I think you have to retake the board, which no one ever wants to do. And if you let the L lapse, then that means you just have to go through all the hoops. So there are people out there probably that just have the OT, but the R and the L are what will actually get you the jobs that you want to be able to have.
That's so interesting because there's not
Yeah.
like PRL, you know,
Yeah.
and like it's
Yeah.
just P. Like
Hmm.
you're hoping,
Yeah.
that's but
Right.
like yeah, PT, and then it's a doctorate program as well, most of them now. So it's DPT, PT, but
Mhm. Yeah. So that's
PPR.
yeah. So that's what those letters mean. You mean something.
I think now there are a couple, or not, I don't know, but somebody that I work with now, she is currently going to, or she's about to go to OT school.
Uh-huh.
And had the choice of like pursuing the doctorate or the master's.
Yeah.
Is there a difference? Do you think, would you pursue, I mean, we're not going back to school, girl, especially after,
Hannah and I
but
were talking about this.
if we're just now entering the field,
Mhm.
do you pursue the master's, or do you think it's worth pursuing the doctorate, or what are your
That's a good
thoughts?
question. I feel like that's a really hot topic in OT right now. I actually just went to a focus group about why would people pursue a doctorate over a master's degree. I just went to a focus group on that like a couple weeks
More
ago.
pay. It's not even more money, more money to pay. Okay.
Um, we're gonna pause this a second because I need to plug in my phone.
Okay.
We said this is gonna happen. One, don't give me a
But
second.
they almost made it because we're literally almost done. We're almost done.
Yeah, it's 10%. Okay, I'm just gonna. Okay, we're back. um, so the rationale for going a program that you will end up with a master's versus a program that you'll end up with a doctorate. Honestly, the main difference as far as the schooling goes, master's to doctorate, is that the doctorate is going to probably require a little bit extra steps as far as research goes. For masters, you are required to do research typically, but that OTD is going to just take it a step further and maybe have a little bit more in-depth research, maybe a little bit bigger project, and maybe extend by like a semester. Sometimes the master's programs are like that close to like another semester and you maybe would have had your doctorate. Honestly, I think a lot of the push for doctorate is if you want to be in academia, you want to be a professor someday. But it's interesting because I think that in order to become a professor, sometimes they're wanting you to have like a PhD. So if I'm being like very clinical based, an entry level occupational therapist with a master's and an entry level occupational therapist with a doctorate degree is probably going to make comparable amount of money. If you have two candidates and one has a master's and one has a doctorate degree, but they're both fresh out of school, you're probably going to make the same amount. Ultimately, from a therapy perspective, a lot of the pay discrepancies goes by experience. So if you have a candidate who is a master's degree, but they've been 10 years, and you have a brand new OTD or doctorate, the master's degree one with 10 years is probably going to make a lot more. So when it boils down to it, it's a lot of the pay discrepancy is going to be experience based. A lot of the doctorate programs are going to look at if you're really, really passionate about research, or you could maybe see yourself in an academic setting in the future. I mean, maybe if you want to be more leadership based, a doctorate might be better. But from just a very basic clinical standpoint, my understanding and where I've gone with this kind of debate is that from a clinical standpoint and a money standpoint, which is a lot of times the question is, am I going to make more with a OTD versus a master's? It's going to boil down to experience.
Yeah.
Yeah. I hope that makes sense.
Oh, it did. It did. It was a great answer.
Yeah.
No, I appreciate this. Thank you
Yeah.
so much. Anything else to tell the listeners? Anything you want to share? The floor is yours right now.
Yeah, I just think, I mean, in general, just therapy in general, I feel like Hannah and I both agree on this, but therapy is just kind of the best job in the world. I mean, it does have its days, but ultimately, how cool is it that as a therapist, we get to empower people? We get to meet them where they're at. And sometimes that meeting them where they're at is like the darkest, scariest time in their lives. And we get to give their life back to them, right? And how cool is it that that's our job? Like we get to meet people of all walks of life, of all stages of life, ages that you probably wouldn't have ever interacted with, and we get to meet them in those like most intimate moments as they're relearning things that they once took for granted, empowering them, seeing those moments of like, wow, I've made progress, I have come farther than I thought I could, and coming alongside them in those moments. So best job in the world. And we love to share it with you guys because therapy's great.
It really
Yeah.
is. Like she said, it has its moments. Ooh, it
It
has
does,
moments,
like
and
any
people will cry.
job.
But for the most part, yeah, it's just like I love being able to help somebody in their journey. And like you said, just regain their life, get back to doing what they love, get back to being with their family again, get back to being home. Yeah, one of my things that we say, well, not my thing, but some of the things that we say is like, I cannot wait. I want my patients to fire me, right? I want to be
Right?
worked out. I want
Yes.
to not need me anymore. I don't want
Yeah.
my job. Do not get it twisted. Not my job. I said I want the patient to
Right.
find
Right.
me in the sense of, yeah, I don't want you to need me, right? I want to be able to give you those life skills, those life tools, to be able to do what you need to do on your own. You
Yeah.
can come back and say hello, but don't come back as a patient. That's why I
Yeah.
don't do.
Exactly. And that is the sign of a success story, right?
Yeah.
Is see them achieving those goals and moving on with their life, right? So yeah.
Well, guys, thank you so, so much for listening. I hope you enjoyed this amazing conversation with Leah. We got down to it gritty. And guys, if you have any questions, feel free to just reach out, comment below comment on our YouTube page or on the Instagram page. Either one is fine. Again, the handle was at BPBD Podcast, like Bent Pages, Bending Bodies Podcast. Leah, our MOTOTRL, get all of the abbreviations correct. Okay, come correct, guys. Put respect on her name. I'm your hostess, Dr. Hannah P. And yeah, we're out.